Dear ladies and gentlemen, thank you very much that you stayed with me until the very end of this session, this interesting session, and the title is also quite long, PCI strategy and concomitant antithrombotic therapy in patients at high GI bleeding risk. And you see here a mountain, and it's going to, on top of the mountain is like to find the proper management of a PCI procedure, and post-discharge antithrombotic therapy are warranted to balance the risk of stent thrombosis, thromboembolism, stroke, and MI on the one side, and on the other side, bleeding risk. So on the right side of this mountain is the bleeding risk, and on the left side is thrombosis and thromboembolism. We already heard that we have some major risk factors for GI bleeding, such as increasing age, previous ulceration, history of GI bleeding, comorbidity, and pre-existing anemia. As you know, we can treat or approach some of these factors, others we can't. On the other side, we have drugs increasing the risk of GI bleeding, as already was shown in the presentations before. If we have a situation we need a triple, or there is discussed a triple antithrombotic therapy in combination with clinical conditions, then we have a problem, and we have to solve this problem. You know, dual antiplatelet therapy in patients with chronic anticoagulants are needed in case of PCI, after a PCI with stent implantation, and patients with atrial fibrillation, as we heard before. And this atrial fibrillation, the indication for a triple therapy is about 70% of these patients, but we have other indications. We can't put in an LAA occluder, for example, in patients with mechanical valves. Then you have to think about triple therapy in the very first time of this after PCI. So the optimal treatment strategy in that patient population on oral anticoagulation having PCI is not clearly defined, and that is associated with a lot of open questions. The questions where they are open is, which stent and what antithrombotic regimen should be prescribed in that situation? Can we use drug-eluting-stents in oral anticoagulated patients? Should we use a triple therapy, a dual antiplatelet therapy? Are there differences between different patient populations? A single antiplatelet therapy, oral anticoagulation and single antiplatelet therapy? Should we use an LAA occluder? We don't have any prospective trials. They compared one against the other strategy. And how long should we treat them with a triple therapy? Shall we assess the bleeding risk? We have some guidelines, and I will discuss that a little bit in the second part of this presentation. Could NOACs be used? Did direct oral anticoagulants be used? We have few data about that. Should gastric protection be prescribed routinely, and what agent? We heard before that in this high-risk situation, we should use PPI without any other discussion. So there's an interesting editorial together with the publication of Rickli. And here there was written that, and it's like that a dual antiplatelet therapy was an exclusion criteria in Aristotle and Rocket AF. So together with rivaroxaban and apixaban, we don't have data together with a dual antiplatelet therapy. And in Rickli, there was a certain subpopulation with dual antiplatelet therapy, but the study is not powered to answer safety and efficacy of dual antiplatelet therapy together with new oral anticoagulants. The absolute bleeding risk on antiplatelet therapy was the lowest, with 110 milligram dose of dabigatran, irrespective of the number of antiplatelet therapy agents used. It can show that if you compare it with anticoagulation with warfarin or coumadin, the intracranial risk was lower in the combination dabigatran 110 milligram in addition to aspirin as compared to the combination of warfarin together with aspirin. So there was a certain conclusion in patients requiring low-dose aspirin, dabigatran might be a safer alternative to vitamin K antagonist. But you have the drawbacks shown here above. So more dedicated prospective trials on this important clinical problem are definitely needed. Coming back to the question, which stent should be used in that high-risk situation? We have here last year published an overview from large registries of 18,000 patients comparing first-generation drug-eluting stents, second-generation drug-eluting stents, and bare metal stents. And here you can see that the risk of stent thrombosis was lowest in the second-generation drug-eluting stents as compared to bare metal stent and compared to drug-eluting stents over 3 years. And the authors concluded that there is a significant excess risk of stent thrombosis at 3 years with first-generation drug-eluting stents, driven by an increased risk of stent thrombosis events beyond 1 year. We know that. Second-generation drug-eluting stents were associated with a similar risk of stent thrombosis compared with bare metal stents, but we had a different duration of dual antiplatelet therapy in bare metal stents versus drug-eluting stents. There was 1 month against 3 to 6 to 12 months. So it's only the focus here on stent thrombosis, and we have to bear in mind that we have thrombosis risk and bleeding risk on the other side too. So there is a recommendation in this book for drug-eluting stents, early generation for sure, not recommended. Second generation drug-eluting stents are accepted, and bioabsorbable stents recommended, and biovascular stents, resorbable stents are also accepted. So now the question, do we have some registries and randomized controlled trial which could help us which strategy we should use in this high-risk situation? We have some. We have some registries. One registry published already 7 years ago in the European Heart Journal was published by a Finnish group to evaluate the antithrombotic treatment adopted after coronary stenting in patients requiring long-term anticoagulation. This patient population, for example, with atrial fibrillation or mechanical valves. The results were that warfarin treatment was an independent predictor of primary endpoint, myocardial infarction, death, major bleeding, odds of 3.4, and the triple therapy was used in half of the patient population. The stent thrombosis was highest, and look at that number. It was the stent thrombosis rate was 15% in this subsegment here, 15% in warfarin with aspirin. It's a registry, it's biased for sure, and on the other side, the stent thrombosis rate in the combination warfarin and clopidogrel was here 0, because it was quite a low number of patients. But here, we can conclude prognosis is unsatisfactory in warfarin-treated patients in this triple therapy, irrespective of the drug combination used. And aspirin plus warfarin combinations seem to be inadequate to prevent stent thrombosis. A second registry, the Danish registry, they assessed the risk and time frame for bleeding following myocardial infarction, not only PCI, also myocardial infarction in patients with atrial fibrillation according to antithrombotic therapy. They assessed 11,000 patients with a mean age of 75, high-risk patient population. And you can see here, the triple therapy is associated with an increased risk over 1 year. The elevated risk was in the early phase, in the second phase, but also it was elevated in the second part of the year after drug-eluting stent or following myocardial infarction. So high risk of bleeding is immediately evident with triple therapy. A continually elevated risk associated with triple therapy indicates no safe therapeutic window, and triple therapy should only be prescribed through our bleeding risk assessment of patients. That was the conclusion of the authors. So heavy data about long-term safety after drug-eluting stents. We have some also registry data. Here it was the outcome of 415 patients with warfarin treatment who underwent drug-eluting stents versus bare metal stents. Here the results, the mean duration of triple therapy was longer. In the drug-eluting stents group, 4.2 months versus 2.1 months in the bare metal stent. Incidence of major advanced cardiovascular event and cerebrovascular events was comparable. Major bleeding events in both groups high, but no difference. And 6 patients in the drug-eluting and 7 patients in the bare metal stent group suffered stent thrombosis. Here, the conclusion was selective use of drug-eluting stent with a short triple therapy seems to be safe in patients with warfarin therapy. The prognosis, however, in this fragile patient population is quite poor, and major bleeding events are common irrespective of stent type. So you can use in this situation also, according to this registry, a drug-eluting stent. And finally, we have one prospective randomized trial, which was already mentioned, the WOOST trial published 1 year ago, dual therapy or oral anticoagulation clopidogrel against a triple therapy of aspirin, clopidogrel, and oral anticoagulation in patient population with drug-eluting stent. Here, after drug-eluting stent, 1 month minimal after bare metal, and 1 year after drug-eluting stent. And here, the same after, as you can see here. And you know that the results were quite impressive. Triple therapy was associated with a high cumulative incidence rate of 44% as compared to the double therapy with warfarin and clopidogrel. And here the TIMI bleeding risk in double therapy, major 3.2 versus 5.6, a major and minor also here. Here it was a significant difference. And what was also impressive, and we couldn't expect, that in this study there was a lower death rate of the double as compared to the triple therapy, and the stent thrombosis rate was not higher in a double as compared to the triple therapy. It went a little bit in the other direction, but it was not significantly different. So the summary of the WOOST trial, we conclude, is omitting aspirin in patients on warfarin undergoing stenting halves the risk of bleeding, does not influence stent thrombosis, and reduces mortality. We have another part, but the trial adopted more aggressive antiplatelet regimen than is recommended in the guidelines. More than 70% of patients received clopidogrel for 1 year, 65% drug-eluting stents, PPI inhibitor use only in 1/3, and the radial access was used only in 25 to 27%. So it was already mentioned that we should or we can assess before we start or decide what we want to do, this HASPLAD risk. It's also mentioned in the guidelines we have from 2010, and you see here that the HASPLAD risk, or in 2 papers from 2010 and 2011, if you have 2 points, then the risk of bleeding, of major bleeding, is below 4%, and here it increases over 4 to 6 to 10 or 15%. And here the actual guidelines from 2010, are now rewritten. They went like that. The first step is to assess the bleeding risk. If you have a high bleeding risk, more or equal 3, then they they recommend to put in a bare metal stent here in the elective setting, the triple therapy as short as possible, 2 to 4 weeks, and aspirin for 2 to 4 weeks, and a lifelong vitamin K antagonist, and you can stop aspirin and clopidogrel after 1 month. And in ACS patients, you have this. I won't go into detail. And if you have a HAS-BLED risk score between 0 and 2, in the elective situation, use a drug-eluting stent, and in the ACS situation, it depends on the complexity of the lesion, what you can use. So, I heard a little bit about the new guidelines which will be published during the ESC meeting in Barcelona at the end of August. And they recommend, first, if you have a situation, patient with atrial fibrillation needing a stent, then if you have here the CHEST-WEST score of 1.3, and you know the HAS-BLED score we have in mind too, but if you have here this situation, if the CHEST-WEST score is 2 or -2, the stroke risk is about 2% or lower, then a dual antiplatelet therapy with aspirin and clopidogrel is safe enough, and you shouldn't use an additional anticoagulation. So let's summarize now what I presented you before. Drug-eluting stents in oral anticoagulated patients, yes. Drug-eluting stents may be considered for clinical reasons, diabetes, chronic kidney disease, and or anatomical, long lesions, small vessel, CTO, in-stent restenosis, if the conditions were if there are conditions associated with a high risk of restenosis. When drug-eluting stents are chosen, you should use new generation everolimus or sotorolimus eluting stents. They should be preferred. Triple therapy with oral anticoagulation, aspirin, clopidogrel is the standard throughout the period of vulnerable to stent thrombosis, but as short as possible, because of the increased risk of bleeding, should be maintained for at least the amount of the time possible in AFib patients. LAA occluder could be an alternative treatment option to replace oral anticoagulation in this patient population with a very high risk, very high bleeding risk. Clopidogrel should be the Y12 receptor antagonist of choice in a triple therapy with aspirin and oral anticoagulation. Coumadin should be oral anticoagulation used in triple therapy until further studies demonstrate NOACs to be a safe option in triple therapy. And coumadin should be closely monitored and dose adjusted to maintain the INR to 2 to 2.5. Prefer second, new generation drug-eluting stents and gastric protection for all cases. So, thank you very much.
So thank you, Hans. Are there some questions? So when you, in your clinic, when you want to avoid the triple therapies and you go after the WUS protocol, so you start right away with clopidogrel and warfarin, or for a short time you may do a triple therapy and then you reduce to clopidogrel warfarin.
Depends a little bit on the clinical situation and on the lesion. If the risk, you can judge also if it is a proximal LAD stenosis in an acute coronary syndrome setting, then we would use a triple therapy for about 4 to 12 weeks like that, but as short as possible. And if we have a very, very high risk of bleeding, then we don't use aspirin anymore. But it's not guideline.